Hello everyone, welcome back to our mini-series on pelvic health. This week we are going to take a dive into some muscular anatomy. Last week we learned a little bit of general information about pelvic health and how OTs can get involved, and so this week we're going to get back to the basics and review some anatomy and some of the structures that are in there. So these are our learning objectives for this week. So I'd like you guys to be able to describe the functions of the pelvic floor, name the muscles and functions and their functions in the pelvic floor, name the muscles and functions of the muscles in the abdominal canister, and describe the function of the respiratory diaphragm, and also describe the function of our supporting muscles to our pelvic floor. So we'll start in with the function of the pelvic floor. So the pelvic floor is the bottom of the core, and it's a big stabilizer for the spine and the pelvis. It provides support to the pelvic organs and also helps us manage our intra-abdominal pressures, maintains our continence, and is a major player for our sexual health. If these muscles aren't functioning optimally, we can run into a lot of issues in all of those areas. So those are the main functions of the pelvic floor. Okay, so let's jump on in to the muscles of the pelvic floor specifically. So we have three layers of major muscles in this area. The first is layer one, which is going to be our more superficial muscles. That is the urogenital diaphragm, and it's going to include our bulbocavernosus and bulbospongiosus, depending on your anatomy, ischiocavernosus, superficial transverse perineal, and all of our external sphincter muscles. So you can kind of see those right through here. So there's that bulbospongiosus, cavernosus, depending on your anatomy, and some of those others. So next, layer two is our deep transverse perineal layer, and it's going to include that deep transverse perineal muscle and our sphincter muscles here, so sphincter urethra, and also there's that deep transverse perineal muscle. Next is the pelvic diaphragm. So those are going to be our deeper muscles, our levator ani muscles, and that includes pubococcygeus, which is made up of pubovaginalis or puboprostaticus, depending on your anatomy, as well as puborectalis, and also iliococcygeus and coccygeus. It's going to also include the hip and pelvic floor muscles, including the piriformis and the obturator internus, which we'll get to more about that in a bit. But they kind of all come together here. So these are those deeper muscles that kind of make up that floor area. So I want you, when we're talking about the pelvic floor muscles, to think of all of these muscles kind of forming the lateral walls and also the posterior superior wall. So kind of that whole little canister sling, if you will. So think of the lateral walls being the obturator internus, and that's going to help rotate our thighs laterally and also hold our head of our femur in place, which is going to help with pelvic stability. The posterior superior wall will be the piriformis, and it also rotates the thigh laterally, but it also can help abduct the thigh, and it too helps hold the femur in place, which can contribute to more stability in the pelvis. So now thinking of the floor, so those again are our deeper sling muscles, so that's the coccygeus and those levator ani muscles. And it's really important to think of these deeper muscles when we're considering things like pelvic floor tension or even weakness. So the levators are the muscles that are giving that lift, and they're the main supporters of all of our organs in there. So if there's tension in those muscles, we're more likely to have pain with intercourse or even just kind of an achy sensation. We can end up with things like prolapse because if those muscles are holding so much tension, other areas are weak. Tense muscles aren't necessarily strong muscles, so it's important to consider both of those options and think about these muscles when you're assessing them and what do they feel like? What do they feel like to our client? So Our deep pelvic floor muscles attach distally to the sacrum and the coccyx. So again, that's important to think about for like tailbone pain and things like that. If the muscles that attach into our tailbone and our coccyx sacral area are tense or tight, we may be pulling that tailbone in one direction, which can cause a lot of tenderness. Just like any other muscle group, when it's shortened and really fired up, we're going to have some soreness there, which can impact our functionality. The levators attach distally to the perineal body and the coccyx, and also the walls of the vagina or prostate, as well as into the rectum and anal canal. So again, if you think we're holding tension in those muscles, or conversely, if they're just not strong enough, which can usually be one of the same, we can end up with things like prolapse and stuff like that. So we want to make sure we're checking the strength and trying to build that. So checking and kind of figuring out what symptoms go with what can help be a tell until you can do an internal assessment. Or if the patient isn't comfortable with an internal assessment, which happens a lot, I think just really tuning into what are they telling you, what is it about the pain that they're experiencing, kind of can give you ideas of that's probably pelvic floor tension versus just weakness alone. So important to address the tension before you jump into strengthening, just to make sure we're figuring out the reason behind the symptoms. Okay, so now we're going to jump into the abdominal wall. So when we start talking about pelvic floor strengthening, it's important to consider the abdomen as well, because these muscles work so closely together, or at least they should be. So let's start with our transversus abdominis. The TA is the deepest layer in our abdominal canister, and it's a large corset-style muscle that originates on the internal surfaces of the 7th through 12th costal cartilage, and also in the iliac crest and connective tissue deep to the 3rd inguinal ligament. The TA inserts on the linea alba with the aponeurosis of the internal oblique and the pubic crest, and then down into the pubic bone via the conjoint tendon. So you can see, I can show with the pointer here, you can see it's inserting right down in here. And our pelvic floor muscles, they kind of all attach right in here too. So they do share a lot of the same fascia systems, which makes them work pretty closely together. So the main function of the TA is to compress and support the abdominal viscera, and it's also very important when considering pressure management, which we will get into that in a lot more detail here in just a bit. So next up is the internal oblique. So that's this big guy here. It's an intermediate muscle that originates in the thoracolumbar fascia and in the anterior 2/3 of the iliac crest, and again that connective tissue deep to the lateral inguinal ligament. So iliac crest and then comes down right in here. The internal oblique inserts on the inferior border of the 10th and 12th ribs here, and then also down into the pubis via that conjoint tendon, again just like the TA. So the main function of the internal oblique is to also compress and support the abdominal viscera, and also it will flex and rotate the trunk. So important in our functional mobilities that we have throughout the day. Next is rectus abdominis, and it's going to originate down in the pubic symphysis and the pubic crest, and then it's going to insert up at the xiphoid process here. And it's used to flex the trunk, and it will also help compress the abdominal viscera a little bit. It's also very important in stabilizing and controlling the tilt of the pelvis. So as you can see, since it does originate down in here, when it flexes, it's going to help pull the pubic bone kind of up into more of a pelvic tilt one way or the other. So if it's more tight, we may shift more into a posterior pelvic tilt. If it's more lax, then we may be more into an anterior pelvic tilt. So things to check into for posture. Lastly, we have our external obliques. They're more superficial, and they originate on the external surface of the 5th to 12th ribs, which you can see right up here. And then they're going to insert on the linea alba. I wish I had a better picture here. You could see how they attach right to that linea alba between the rectus bellies. The main function of the external oblique is, again, to compress and support the viscera, and they're also going to flex and cause rotation in the trunk. And of course, that's an oversimplification of what they do, so more on that probably in a different webinar. So our last slide, we looked at the anterolateral abdominal wall. Now we're going to look more at the posterior abdominal wall. So these muscles are all still very important for our pressure management system, and also just our overall postural strength and functionality of our pelvic floor, because as you can see, they all attach very much down into the pelvis. So the first one we're going to talk about is the quadratus lumborum, and that's this guy right here on each side. It laterally flexes the vertebral column and also fixes the 12th rib during inspiration. So you can see that 12th rib right here. So when we're taking a big inhale, it's going to help kind of keep those ribs grounded. I'm not going to go into as much detail about origins and insertions of these muscles. That's something you guys can look up. Next is our psoas major. So we've got our psoas right here. Pretty good sized muscle. Attaches to the vertebrae and also down into the thigh. So psoas major is going to act inferiorly with iliacus, which iliacus is right here. So they're going to work together to flex the thigh, and then psoas will act alone superiorly to laterally flex the vertebral column. So it can work with iliacus or it can work on its own. So when you're in a seated position, psoas will again work inferiorly with iliacus to flex the trunk. Psoas is also a stabilizer and acts to balance the trunk. So our iliacus muscle here flexes the thigh and also stabilizes the hip, and like I said, it does work very closely with psoas, so you may hear them grouped together as the iliopsoas muscle. Let's see, and also in our posterior abdominal wall, we do have the posterior fibers of the transverse abdominis and also the respiratory diaphragm. We're going to go more into the respiratory diaphragm in just a minute, and the TA muscle functions just how we just discussed. Okay, now we are going to talk more about the respiratory diaphragm. So the respiratory diaphragm is incredibly important in regard to pelvic health. It works with our abdominals to manage our intra-abdominal pressure, and also should be working with our pelvic floor to help manage that pressure. So pressure management and our diaphragm, how we're breathing, all of that is very important to assess and take a very close look at, especially in clients with things like stress urinary incontinence and pelvic organ prolapse. But I would encourage you to assess this in all of your patients, because while they may not be having some of these pressure issues now, if they do have poor pressure management, it's something that can happen in the future. So something to kind of keep an eye on. And definitely educate about. So when we kind of start looking at pressure management and looking at how the diaphragm works, we're going to look at first how the oblique and transversus muscles work together to form kind of this muscular girdle that exerts pressure on the viscera, and that's how we increase our intra-abdominal pressure. Our rectus muscles, the rectus bellies, don't really have too much to do here. They're not really participating in this aspect. It's all the obliques and the TA muscle. So compressing the viscera and increasing intra-abdominal pressure will elevate the relaxed respiratory diaphragm, which causes air to expel during the exhale. So that's going to be what you see here in this diagram. And it's also what happens during like a cough, laugh, sneeze, blowing your nose, things like that. There's an immense increase in pressure, and that's where we have to have the strength in our pelvic floor and the proper body mechanics to manage that pressure well. And then when the respiratory diaphragm contracts during an inhale, those anterolateral abdominals relax and expand to make room for the viscera. And also the lungs as we take in more air. So that's what you see in this picture here. So when we are breathing in, we're taking a big inhale here, diaphragm contracts down, abdominal muscles relax, allowing to create space, and our rib cage is also going to open up. So think like opening an umbrella when you inhale, everything comes out at nice 360 degrees. And during all of this, our pelvic floor is working with the diaphragm. So pelvic floor and diaphragm should mirror one another and work together. So when we inhale and the diaphragm contracts down, the pelvic floor is relaxed and down. When we exhale and the diaphragm relaxes and comes up, pelvic floor should come up as well to help accommodate for that and maintain the pressure system. And quick side note here, the actions of those anterolateral muscles also produce the force that's required for proper defecation, urination, vomiting, and childbirth. So like I said before, increases in pressure without the adequate muscle support is going to contribute to things like stress incontinence, pelvic organ prolapse, hernias, but also pelvic floor tension and all kinds of muscle dysfunction because the muscles just aren't able to go through their contract and relax patterns correctly. So I'd encourage you again to just take a close look at how people are breathing, what are those mechanics, and they may look at you like it's a little silly, but if you just explain to them the benefits for the pelvic floor, I think that they'll understand, and usually patients, once they've figured it out, are pretty receptive to this education and really find it a lot of fun. So that's the respiratory diaphragm. Okay, so now we're going to chat more about the lower extremity supporting muscles here. So there's quite a few. Our pelvic floor doesn't do it alone. We want to kind of look at the entire picture and look at all of the muscles in the system. So we will start with the gluteal muscles. So glute max is going to work to extend the thigh and assist in lateral rotation. It also stabilizes the thigh and is active during sit to stand movements. So that's going to be this guy right here. Glute med and glute minimus both abduct and medially rotate the thigh. They also work together to keep the pelvis level when the ipsilateral limb is weight bearing. So these muscles are very important during the swing phase of gait. So keeping the pelvis level, which is going to make for pretty happy pelvic floor muscles. And then we'll do a quick note on piriformis, which is this guy right here. We talked about piriformis a little bit earlier, but it's going to work with our obturator internus, which is not pictured on this slide. Both of them together are going to laterally rotate and extend the thigh, and also they can abduct the flexed thigh. So again, very important during steadying that femoral head into the acetabulum. So pelvic stability is what we're going for here. We want to make sure we have good, strong, stabilizing muscles to help encourage the pelvic floor muscles to work optimally. If any of our glutes are not working correctly, or they're too tense, or they're too weak, or a combination of the two, we're going to develop compensatory patterns, and maybe our pelvic floor is one of those muscles that's compensating to kind of bring in that stability. So we want to make sure we've got good strength and good muscle health in all of the tissues. Next is our hamstrings. So we've got a few muscles here. So semitendinosus and semimembranosus work together to extend the thigh. They also will flex the knee and rotate it medially when the knee is flexed. And then when the thigh and leg are flexed, they can work to extend the trunk out. Biceps femoris, this one right here, flexes the leg and rotates it laterally. When the knee is flexed, it also extends the thigh with acceleration, such as like that first step in gait. So important, again, just for steadying the pelvis. The hamstrings are also going to be important in managing pelvic tilt. Because of the way that they attach, if we are too anteriorly rotated or too posteriorly rotated, our hamstrings are affected in that, and that can reduce our pelvic stability as well. Next, we will talk about our quadricep muscles. So again, we'll kind of just breeze through these. So our quadricep muscles, we've got rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, and they are all going to work together to extend the knee. And then rectus femoris also steadies the hip joint and will help iliopsoas flex the thigh. So because of the way that they connect, you'll see rectus femoris comes up a little bit higher, so it can work with the iliopsoas, which attaches up in our lumbar spine and then down into the leg here, so they can work together to flex that thigh. So now we'll kind of bring it all together. So why is anatomy important? Um, I'll be honest with you, I don't have every muscle ever memorized. I do generally have an idea of where things are and where I'm poking around, what muscles do what. But I think it's important to have kind of a gross grasp on the general anatomy in the area. And with practice, more of that will come to you. But if you don't know the actions of the muscles, it's really hard to treat or know what you're looking at. So, in order to get a more complete picture of your client, you do need to know what happens when this muscle is weak. What should I look out for when there's hypertonicity in the pelvic floor? What symptoms should I look out for? What ADL could that impact? How is their life impacted? Because at the end of the day, we're not necessarily looking for perfection, but we are looking for function. So we want things working as optimally as they can. And when you start looking at the muscles and you're seeing the different compensatory strategies that patients come up with, it's really interesting. And you may find yourself even treating more in the upper body in order to get the compensations in the lower body to calm down a little bit, or seeing how the posture of the upper body affects the lower body. It is all connected after all. Could probably do a whole nother lecture on just the fascial system alone. So I'd encourage you to pull out your anatomy books and just read through and get a refresher on all of that. I know my OT program didn't talk as much about the lower extremities as I would have liked, so this whole thing's been very enlightening for me. I use the More anatomy book, and I've really enjoyed it. It's got a lot of good just clinical pearls and things to help tie function to those muscles, and I think that that's the best advice on how to learn a muscle is just tie it to a function, and then you'll never forget what it does. So that's why anatomy is so important. And then any questions or comments on this? I know we kind of breezed right through a lot of this anatomy. I did want to keep it kind of general just to give you an idea of what muscles we're talking about here, what they all do generally, so we know how to treat them a little bit better. So if you have any questions or comments, please send me an email, reach out to me on social media. I do plan to do a fifth video that talks all about any questions that have come up during the course of this mini series. So I want to make sure that we're answering all those questions for you. So please reach out. I love to learn, and I appreciate you taking the time to watch these webinars. So have a good rest of your day.